Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. It's very difficult to talk to you, and we have among us senior and well-known pathologists like Dr. Ashraf Ali and Dr. Fuad Dail, but I will try to do my best. Okay. So it's a great pleasure to be here, and a great pleasure to talk to you about the PDL1. So the outline of my talk, first I'm going to talk to you about the new International Association for Study of Lung Cancer Atlas, which actually the guideline for the pathologist who going to do PDL1. It's comprehensive, it's 135 pages, and it has everything you want to know actually about PDL1 testing. Most of the things that has it in that atlas is the standard. There is some research issue, or there's some new testing. I'm going to mention it a little bit. It's not included in that atlas, as it is not still the standard. Then I'm going to move you to the cancer immunity cycle in our body, how it works, and why most of our tumors are non-immunogenics. And this is give opportunity for immunotherapy to treat those cancer. And then I'm going to talk to you about the PDL1 immunostain as biomarker, what is the indication, and how we report the result. I'm going to also discuss some of the pitfalls, since all of you working in pathology, some of the pitfall in reading actually or reporting immunostain of PDL1. And also the CAP proficiency, they step up and they now have some proficiency testing in PDL1. Other biomarker at the end, because as probably you know that PDL1 is not a perfect biomarker, so it is a very hot subject, and I am sure in the near future we're gonna see some either alternative or some combination with PDL1 testing. And then summary. So let's start. This is Atlas. The Atlas is 132 pages, not 135. It's published in 2017. A lot of famous people work in this Atlas, among them famous lung pathologists. So they really work hard in this one, apparently, and it's very comprehensive. And because I am giving this lecture, I have a chance actually to read most of the Atlas. So basically, our immunity cycle, that if we have a tumor cells, the tumor is releasing antigen. This antigen will be captured by the dendrocyte or antigen-presenting cells. And then the antigen-presenting cells will influence the lymphocyte and causes a lot of pooling of the lymphocyte to go with some priming activation to go and attack the tumor cells and get rid of the tumor by apoptosis. And this is the apoptosis phenomena where the antigen-presenting cells actually activated the CD8 lymphocyte. The CD8 lymphocyte actually get into the tumor cells and making a hole in it, and that is ending these cells by apoptosis. In order for the cancer cell to survive, it has to evade actually this immunity process. So evading the apoptosis. So how the tumor cells do this? It do this is by several mechanisms, has been described actually in the literature. One of them is, for example, the MHC, the major histocompatibility, is to causes either gene loss or mutation. So there is no binding between the antigen-presenting cells and the lymphocytes. So it cut that one. One of them is secretion of immunosuppressive cytokine. This is creating microenvironment to prevent actually also this cycle from happening. One of them is induction of immunosuppressive T cells. This is called T regulator cells. Those are suppressor for the apoptosis. And now actually as new biomarkers, some of them, they measure those T regulatory cells. And then general failure of immune competence in the patient. And the last one, which is the most important one, is a series of immune checkpoint regulator, those binding, as you see them here, to inhibit actually the activation of the lymphocyte. One of those is CTLA4, and one of them is the PD1 in the lymphocyte and PDL1 in tumor cells, and those two major actually target for immunotherapy. So we know now that the tumor is divided into two kinds. One is the cold tumor and one is the hot tumor. The hot tumor, or the inflamed tumor, is a tumor that harbor a lot of lymphocytes. Majority of them, they are cytotoxic CD8 positive lymphocytes. But they are really not necessary to be active. We know now that the tumor that harbor those cells more likely to have PDL1 expression if we do the immunostain, and most likely also to be benefit actually from immunotherapy. So we start seeing some reports when they report lung cancer to also mention those lymphocytes, that there is presence of lymphocyte within the tumor. Which lymphocyte that really significant here in related to immunotherapy? Two kind actually. And we're going to talk at the end of the lecture about something called immunoscore. So either will be those lymphocytes within the tumor, so they are intimate relation with the tumor cells. That is one. And the second one actually is to be near the invasive margin. So if the tumor go toward invasion, so here also those lymphocytes, also those are very significant. Any other lymphocyte away from the tumor, they are not significant and should not be used in immunoscore or in interpretation, hot versus cold. Now, PDL1 immunostain is the most common biomarker using now for immunotherapy, although it is imperfect, and we're going to see why it's imperfect. One of the reasons imperfect actually because if it is positive, it means that really the patient will benefit from immunotherapy, but if it is negative, it does not really exclude total benefit. And there is some other limitation that the oncologist and the pathologist raise it. One of them, for example, is that we have so many antibodies. Now we have 5 of them, and how to deal with each one. Well, this is a pre-analytical condition. If you want to implant this immunostain in your laboratory, you have to take care of all those conditions that has been also described in the literature and also described in this new atlas. One of them, for example, it's not recommended to use paraffin block if it is more than 3 years old. One of them is related to the time of fixation, similar to any immunostain that is now considered prognostic, and so that is what. If you're going to use also decalcification, for example, EDTA, some other things, they mention it all in this one. Normally, when we receive a specimen, you need actually to either, if you have really diagnosis of cancer, you could start cutting the specimen. That is all of them according, some for H&E, and then followed by some for the immunostain and some for molecular testing. So PDL1 will be among those with immunostain. So in order actually to preserve the tissue as possible. And now this is the algorithm for a lung cancer. If the lung cancer actually comes with biopsy or cytology or core needle biopsy or resection, the first goal is to establish firm diagnosis. The firm diagnosis can be done in H&E, or we might need some additional immunostain. We do it once, and we need to minimize those ancillary testing because we need to preserve the rest of the tissue actually for some other marker. So if it is adenocarcinoma or adenocarcinoma component, we will start with molecular testing, which is a priority, EGFR, ALK, and ROS1. And if it is positive, that's it. But if it is negative, we're going to continue to do PDL1 testing. And for squamous cell carcinoma, we go ahead with PDL testing. We skip the molecular testing. And as you see, we have now 5 of those. A few months ago, we only have 4. Now it's more complicated, actually, by adding a new antibodies, that the 7310. So now we have 5 of them. And you need to choose one that is really corresponding to what is the oncologist going to use. So basically, those are the 5, and those are the company who brought them. 3 of them now from DACO, and 2 from Ventana. And each one of those has a special staining platform. Means if you have DACO machine, DACO has 2 machines for immunostain, you cannot use it in any one. You have to use the one that is got FDA approved, for example, which is the link 48. For Ventana also, you have to get actually the benchmark or the ultra. That's both of them will work for the others. PDL1 is a continuous expression. It's not positive, negative like the molecular testing. You see here, for example, EGFR, ALK, and RAS1 is binary, the result, either positive or negative. And we have definition for positivity and negativity according to the method that we do it. But for PDL1, it's a continuous process. Lymphocyte always in dynamic change. So it has to be expressed in certain percentage. So you need really to come and calculate what positivity in all the material you have to come up with number, and then you convey the message to the oncologist. And according to whatever medication they're going to use, they have different cutoff. Or whether they're going to use it first line or second line, they have different cutoff. So some of them 1% will be enough. Some of them they need 25% here. Some of them, for example, the 22C3 using 2 cutoff, one low positivity more than 1% to 49, let's say, and one more than 50% or more. So this is high positivity, low positivity. Some of them like SP142 using tumor cells and using lymphocyte also. So you need also to come up with what percentage of lymphocyte positive for PDL1 stain. And this one, it is challenging. We're going to see SP142 for Roche company, little bit challenging because not only because it's using immune cells, but also it's accept cytoplasmic staining. All the others is using only membranous except the SP142. Okay, it's a stop. Okay. So in the atlas, actually, each of those 5 antibodies, they bring you suggested reporting, what you need to report. The most important, actually, first to adequacy. The adequacy, you should have at least 100 cells, so you will say. And the second to the adequacy, the control, positive control and negative control. You need to say it is okay, it's passed. So you have to look to the control first. Adequate sample, and then you go and report the PDL expression percentage according to any given antibody. So each one of those has different. And then they put for you the optional information, if you have any immune cells, significant immune cells, and also you try to report, it's better to report actually the percentage in 10% increment. So you don't say 61, you say 60. You don't say, let's say, 35, you say either, you round it. So in 10% increment, that would be better and more reproducible, because they done some study. There is about 10% variation between pathologists. So 10% will be less likely to have this one. Again, those are the 5 immunostain as you see them here, and the PDL1 binding domain for the SP142 is okay with cytoplasmic. And you're going to see those how we read it. So this is the 7310, the new one. Show heterogeneity. This is squamous cell carcinoma. As you see here, it's positive in part, negative in part. And that's also expected. I mean, don't say this is a staining pitfall. It could be some area totally positive, some area negative, or it could be even in a solid area, half of it positive, half of it negative. That is also seen. So those are the two big machines that used either the DACO Link 48 or the Ventana machine. And they could use it corresponding to the antibody. And normally we receive it in a kit that have positive control, negative control. So everything ready actually to go and to do the test, which is easier than to get it free antibodies. Now, the question is, what if I use one machine for all those? They done something called the blueprint study. The blueprint study, 4 of those who previously approved, not including the last one, they come together and they sponsor a study to try to get the same tumor run on 4 antibodies in one machine to see if they're getting the same result. And actually the result of it that 3 of those antibodies, the 22C3 by DACO, 28-8 by DACO, and 26-3 in Ventana, they are really giving similar results. The one that is different is the one that is SP142 for Roche company, that's run on Ventana machine. That is different. So, and here you see some example. This is positive, 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 but not this one, very positive like the others. So less expression. And here the same for, the other one, as you see it. So they concluded that you could use actually any of those 3 antibodies will be okay, but not for the last one. So what are the diagnostic fault in reading those? There is a lot of diagnostic fault. Number one, you have to make sure if you are using cell block material, for example, or a biopsy, core needle biopsy with a lot of dysplasia, very few tumor cells, you have really, before ordering the stain and spending money, you have to look for how many cells I have. It should be more than 100 cells. If you have less than 100 cells, do not order it. Because even if it is positive, it does not mean that is really reliable result. So you need really to this one. Now, PDL1 also offered on liquid biopsy. Liquid biopsy has a few, actually, tumor cells. So still it is not really widely used because of this. And the Atlas did not discuss, actually, the liquid biopsy because this is still, actually, in research, idea, clinical validation, and all this. Then you have to look for the control. You could use the control provided by the company, or you could have your own control. Some of the good control, for example, the tonsil is excellent one. Also, you could use, other than the tonsil, the placenta. Placenta has a lot of PDL1 expression, so also you could use it. Then majority of them, except the SP142, we're gonna look for only membranous staining. So only membranous. If it is cytoplasmic, we don't count it. And we accept membranous whether it is partial or complete. For HER2/neu, we need it complete. Here, we accept it even if it is partial. And also, we are looking with all of them, except the 142, for a tumor cells only. So you need to look for your specimen, not to count any histiocyte, not to count any lymphocytes, stromal cells that might stain with PDL1. And then you report it, either high positivity, low positivity, or negative. So this is how we report it, and we need to present it in 10% increment, as mentioned. Some of the pitfall, necrotic area, you don't count it. Granular staining of the cytoplasm without membrane, you don't count it except in SP142. And then also the cytoplasmic staining will be counted if you have membranous staining, except in 142. Necrosis, you don't count it. Alveolar macrophages, which is abundant usually in lung tissue, you don't count it. Okay, lymphocyte staining, you don't count it unless it is SP142. And then the heterogeneity of the tumor, as I mentioned. Sometimes you'll find area totally negative, near to it totally positive. So you need to concentrate on the positive and take percentage of all your slide. Background staining, like in any immunostain, edge artifact in any immunostain. And if you have in your slide 2 or 3 areas separated completely from each other, you treat each one separately. What percentage of number 1, what percentage of number 2, what percentage of number 3, then you take the average. You don't take all of them in one time. Now the inter-observable variation is present, as you see from some study, it depending on the clone. For example, the 22C3, as you see, some reported 7.4%, some of them 16%. So this is why actually the suggestion by the atlas to make a 10% increment, it might decrease this one. CAP, they will send you 10 slides to do it, and they already have the answer, then they could share it with you. And now you could do PDL1 in liquid biopsy. As you see here, some they advertise for it. They collect those circulating tumor cells as step number 1. Then step number 2, they do immunostain, and they do immunostain whatever you want from whatever antibody you are interested. Because PDL1 is not a perfect marker, people start searching for alternative. Or for other, they could use it with PDL1. And we have now big list actually of those. I'm going to go quickly for some of them. So one of them is the CD8 positive lymphocytes. Most of those studies, they concentrate actually on 2 things. One is the tumor cells staining, that is, or the mutation in the tumor cells. The other one is the lymphocyte CD8 positive. They will look also for method to stain it, or they could also do some clonality studies in it. So CD8 can be done by flow cytometry, the standard procedure in any pathology, but this won't be benefit at all, because this will take all the lymphocyte. You have to extract the lymphocyte from the tumor and then run it in a flow cytometry. It will mix it. You don't know if this is really within the tumor or away from the tumor. So this is not acceptable. The acceptable, actually, you could do PDL1 in one side, CD8 in one side, and they try to come up with a number of positivity. So some people, they use both to mention if it is positive or negative. And we saw the SP142 that is taking into account this one. Now the CD8 you could do. Okay, about to finish. So here we have, you could do multiple actually immunostain, multiplex immunostain as you see it in this abstract, either by immunostaining several, one staining the CD3, for example, CD8, you could do cytokeratin for the tumor cells. So you could actually use those multiple marker. And one of the method also they are using it, or they describe it actually, at least in a few papers, is the multispectral microscopy, where you use several markers using fluorescent antibody. Watch for this one, for example. This is a DAPI for DNA, just to show you the number of viable cells. Then you could add to it, for example, CD67, which is the blue. You could add to it also CD3, which is the yellow. You could add also CD20 to see what the 20 cells, CD20 present. And you could add it IgD, for example. So 1, 2, 3, 4, 5 in the same tissue. So you see the relation between them and you can take the percentage. They done it actually, those are PDL1. The PDL1 actually here in green, as you see the tumor cells. And then the CD8 cytotoxic in red. So you see the intimate. You don't count those, you counted the one that is really near the tumor, and then the CD also 3 in yellow. So they use it actually in order as a biomarker. Immunoscore is another way, actually, to another biomarker. They are talking about it as alternative for PDL1 or add-on. It depends actually in the immune cells, mainly on CD3 and CD8 cells, and you need to stain them intra-tumor, so tumor center, they call them, and you need to put what is low or high or absent, and also invasive margin. You need to put also absent or low in number or high in number. Then you come to the score that is indicative actually if this patient is gonna benefit from PDL1. Now suppose you have two tumor, one is MCI and one is stable, microsatellite stable. The one expected to be in stable, actually, it's supposed to have high PDL1 expression. It's supposed to have a lot of cytotoxic cells, and this is usually prolonged survival. If you have microsatellite stable tumor, the PDL1 will be low, and then also the lymphocyte cytotoxic will be low. So this is actually one also they use it, the immunosuppression score. The immunoscore will be low here, here will be high. What else we have? We have actually, for example, on the lung, either will be peripheral lung or central. We know the central is arising from the conductive airways, while in the terminal it is from the exchange airways. So for tobacco, this is the one that exposed more. So this is either will be squamous cell carcinoma or will be small cell carcinoma. And this has been shown large number of mutation comparing to the one that is from the peripheral, which is the adenocarcinoma. So this is, we call it genetically complex cancer, and this one will be simple, genetically simple cancer. This has more mutation than this one. So this is give the idea of what we call it the tumor mutation burden or load. What is the quantitative number of those mutation in the tumor cells? So they use it actually, and you see it is really correlate with the response to immunotherapy. So it is a good biomarker for immunotherapy. And as you see it here also, it is correlate actually with PDL1 expression, and you could add to it also gene signature also. Now you could add also MSI, and they found that the MSI tumor, majority of them, they have tumor mutation burden high, 83% as you see here. And the most common tumor, which come here in dark green, you're going to find it in the RGI or GYN in origin. So MSI is another biomarker, work very well in certain tumor like GI and GYN. So in summary, we have now choices in methodology to distinguish between really tumor that not benefiting from immunotherapy and the tumor benefiting from immunotherapy. So we could use any one of those, including now we are using the high PDL1, that is the one in use, and I am sure potentially in the future we're going to narrow this list into a couple of those. With this, I am done. Thank you very much.